So in 1999, we presented the protocol to The Lancet. They published that. And as you'll know, that target is a word that I coined called TARGIT. And this is the Data Monitoring Committee and the International Steering Committee. And you can see illustrious names in that photograph. The trial has a very broad inclusion criteria: age more than 45 years, tumors preferably less than 3.5 centimeters, and we excluded globular cancers. And remember, this is not target versus EBRT. It is risk-adjusted radiotherapy versus one-size-fits-all radiotherapy, which is whole breast radiotherapy for everybody. And patients in the target trial received target, and if they were found to have high risk, they received whole breast radiotherapy in addition. We predicted back in 1999 that external beam radiotherapy would be required in about 15% of patients and powered the trial in that manner. And in reality, it happened in 14%. So our prediction was quite right. It is a non-inferiority trial. First patient was randomized in March 2000. 2,232 patients were randomized from 28 centers in 9 countries. The maximum follow-up is 10 years. But median follow-up of patients needed to prove a non-inferiority margin of 2.5% is 4.5 years. Analysis is by intention to treat, and outcome primarily is local recurrence. These patients were generally good prognosis, although we didn't specify that. They happen to be the case. But they're not elderly. They're not very tiny tumors. 82% of patients were less than 70. 64% of patients were more than 1 centimeter in size. But more than 2 centimeters were fewer, so were grade 3 node positive or ER positive. They were good prognosis patients. The two groups were well matched in terms of their prognostic factors. In terms of their surgery, now the surgeon couldn't be blinded. We were told, one of the ethics committee responses was, the surgeon should be blinded to the technique. Now that would be difficult. So the surgeon was not blinded. So we looked at the specimen size and specimen weight and re-excision for margins. And that didn't differ between the two groups, suggesting that the surgeon didn't do particularly differently in terms of the operation. There was no difference in major complications in the two groups. We were concerned we may have complications with wound, but we didn't. The two differences appeared in statistically significant, but as you can see the numbers, seroma needing aspiration was 2%, 2.1% versus 0.8%, a little slightly increased, whereas grade 3 toxicity because of radiotherapy was also slightly increased, 2.1% versus 0.5% in the external beam radiotherapy group. That just also suggested that the whole breast radiotherapy these patients received was good quality. Evaluation of these patients afterwards in terms of mammograms was not difficult, and this is recently published of 100 patients. There was no difficulty in evaluation of mammograms in these patients after IORT. Now this is the main slide showing hazards of local recurrence of target versus EBRT. As you can see, every year the blue and the yellow, blue and the red, or the pink, are very similar to each other in terms of hazards of local recurrence. And the two lines of local recurrence of the Kaplan-Meier curve are on top of each other. The difference, the absolute difference in local recurrence at 4 years was 0.25%, and they were 0.95% versus 1.2%. So we had accepted originally a 2.5% difference as non-inferior. Reality, we found 1/10 the difference. So we were very, very reassured. So we say we have established non-inferiority of 0.25% with the upper confidence limit of 1.5% at 4 years. This was published online in The Lancet, and we got pretty good reviews. And it said it was for selected patients. And this is where you'll find a difference between only IORT versus risk adjusted. We analyzed this data according to the ASTRO guideline, just as Professor Orekia had done. And you all are familiar with these 3 groups. We divided in 3 groups. 700 patients out of the 2,000 were in the low-risk group. 900 patients in the target trial were in the high-risk group. So that is a large number. And the remaining were in the medium-risk group, cautionary group. And what happened to them? The Kaplan-Meier plots, in every group, there was no significant difference between the target group and the EBRT group. And these are the numbers of local recurrences in these 3 groups. And there was no difference in terms of the difference between the 2 groups at all. As you can see, the difference between the local recurrence of TARGIT versus EBRT in the first line is in the whole trial. Second line is the second. Cautionary is 0.79 and unsuitable is slightly below the 1. Now this shows how elegantly this technique is risk adjusted. Most patients in the suitable group receive TARGIT as the only treatment. But one quarter of the patients in the high-risk group received whole breast radiotherapy as well. But what does it matter? 3/4 of the patients in the high-risk group had TARGIT alone. So they got away with that as their only treatment. If we had excluded them initially, they wouldn't have had that benefit. And they achieved the same outcome. So it delivers individualized risk-adjusted radiotherapy. In terms of quality of life, this is the work of Professor Wenz. EORTC quality of life analysis, we found that TARGIT has significantly less pain and fewer breast and arm side effects, significantly higher patient satisfaction. The cost effectiveness of IORT has been analyzed by Dr. Michael Alvarado from UCSF, and this might be very interesting to you. What he found is that after very good Markov modeling, that whole breast radiotherapy would be cost effective only if the IORT local recurrence at 10 years was 22%. Now, that is nowhere near reality. IORT local recurrence at 4 years is 1.2%. And if you look at it the another way, is that IORT saves $6,000 per patient. And if you count the number of women who are able to receive this treatment, the economic burden to the US economy, if TARGIT is not implemented for the next 5 years, is $1.4 billion. In these austerity times, can you afford it? We analyzed, after having done the data analysis last year, 9 months had passed. There was pressure on us to see whether we could analyze the data again. Now, it is not good practice to keep analyzing the data between the two arms. So what we decided is to remain blind to the number of recurrences of which arm they were in, and analyze them in terms of total cohort. So here you see the two lines. They are not the two arms of the trial. The blue line is the Kaplan-Meier plot with the data as we knew in the Lancet publication. And the pink one is now as we presented in St. Gallen. The overall event rate in the whole cohort has remained unchanged. It was 1%, 1.08% in June last year, and is 1.09% in March this year, suggesting that it is unlikely that we are going to have a sudden increase in the local recurrence in one arm that would have skewed that result. And as you can see, at 4 years in the Lancet paper, we had 420 patients, and now we have 700 patients who have at least four-year follow-up. This gives me great reassurance that we are probably right. This received a lot of publicity. NCI, JNCI, Independent and Sunday, a lot in Times of India on the front page in every city, New York Times, LA Times, and recently in the Daily Mail. But the most important one, I think, is the one that when it was discussed in the St. Gallen meeting, which is held every 2 years in Switzerland. And at the end of the meeting, there is a consensus meeting on a Saturday morning, which lasts for several hours. Questions are asked, and experts like you sit and vote to decide what should be the standard of care for the next 2 years. And these were the questions that were asked, and it is giving me goosebumps just now. In association with breast-conserving surgery, partial breast irradiation, and they have said into bracket intraoperative, not anything else, is acceptable instead of external beam radiotherapy. Boost, this is for the boost. I have not given data about the boost now. 60% said yes. Now this is unselected patients. In association with breast-conserving surgery, partial breast irradiation intraoperative is acceptable as a definitive radiation without any external beam radiotherapy. 48.9% said yes, 35% said no, and 15% said don't know. By first past the post, TARGIT has won. And even better result was for elderly women over the age of 70, 86.7% said yes, this can be the definitive treatment. Only 6% said no. And that I consider, I keep pinching myself that this is reality. So in conclusion, at 4 years, the local recurrence rate in the target group is not statistically significant from the EBRT group. Risk-adjusted target approach is applicable in all 3 ASTRO risk criteria, as long as you make sure that your high-risk group gets whole breast radiotherapy postoperatively, and should be overall about 20% of patients. The overall local recurrence rate has remained stable over a longer follow-up. What I have not talked about today is the target boost data. I don't know whether I have time for that. I'm not. And in that will go target boost study. Conclusion 2 is that target has lower radiotherapy complications. Target alone has better quality of life. The St. Gallen consensus meeting voted in favor of target, and not implementing target could cost the US economy $1.4 billion in the next 5 years. This is the vision, the reality of risk-adjusted radiotherapy. In low-risk group, we could receive target alone, and in high-risk, women younger than 45, we have found that the local recurrence rate is probably superior with a target boost, and that's why we are trying to do a superiority trial, which will launch very soon. And that is moving towards reality. And in the US, the target US registry study has been with a target boost, and that's why we are trying to do a superiority trial, which will launch very soon. And that is moving towards reality. And in the US, the target US registry study has been established. And you can see there Dr. Michael Alvarado and Dr. Eleanor Harris as the co-chair, Dr. Dennis Holmes and Dr. Bill Small as the 4 members. So you can register for this, and for selected patients can be entered onto this registry trial, which will roll out very soon. I wish to thank the Clinical Trial Center, and thank you very much.